Professor Dr. Sami and her distinguished team for being there with us. Without you, it wouldn't have been. I have East China University and other provinces as well. So thank you so much. We are all very appreciative. Again, I would like to thank the organizing committee for such a distinguished conference, Professor Maggie, and the organizing team, Dr. Hana, Hamdi, Dr. Mohsen, Dr. Emil, Dr. Musa, and Mihal Rifai, yes, and Dr. Mihal Rifai, and the rest of the organizing team, a very distinguished conference. Well, all the rest for you guys. Next, I would like to introduce our next speaker, Dr. Chris Taffy. He is the MD, he is the head of the
Growing cystic fibrosis, the case presentation. This is one of our patients, came 4 years old, who was first sibling of a consanguineous marriage. He had normal developmental milestones with no history of E.U.P or hospitalization. His family history is irrelevant. Birth weight is 3.5 kilograms. He was both breast and bottom fat. And he presented to our gastroenterology clinic complaining of chronic diarrhea for about 2 years duration, 7 times per day, stool described as greasy, foul smelling but no mucus or blood, no bilious emesis, there was failure to thrive, recurrent abdominal pain as well as marked abdominal distension. And since early infancy he suffered from some breathing intolerance, and on physical examination his body weight was 12 minus 3.2 standard deviation and the length was 90 centimeters, also minus 2.5. Then the family started to seek medical advice at that age. The full workup revealed some microcytic, normocytic hypochromic anemia, stool analysis showed acidic pH and some fat cells, with all electrolytes came normal and albumin normal. And in this condition, first, should we go directly to cystic fibrosis, or should we rule out other causes of chronic diarrhea that is common in such patients? We have failure to thrive, chronic diarrhea, feeding intolerance, and abdominal distension, and some microcytic hyperchromic anemia. Could it be celiac? And we did first the celiac workup with the 4 years old with this marked abdominal distension and anemia. Usually we think first to celiac anemia. And accordingly, if you are suspecting a celiac disease, then we are going to measure the total IgA and serum TTG-IgA. And the TTG-IgA came positive and the test was 150. According to this level, should we consider this patient as celiac or should we proceed further? Yes. So our next step is either one of two things according to the guidelines. Either you perform an endometrial antibody IgA or perform an endoscopy. And this is the algorithm that we are looking for. If it's more or less than 10-fold, we go directly for biopsy. If it is more than 10-fold, you have either one of two things. Either you do the anti-endometrial IgA or do for the biopsy. And in our unit, the endoscopy is easier than the stool analysis. So we perform the endoscopy. They don't do stool analysis, but don't know how to select the stool. So the easier is the endoscopy for everything. Endoscopy for every patient. So we did an endoscopy for such a patient. An upper endoscopy shows normal findings clinically. However, if we see that this whitish spots and the festooning could point to celiac. However, the duodenal biopsy showed mild focal shortening of the spinal villi with increased intraarterial lymphocytes more than 30, and this is considered MARSH 2. And accordingly to the modified MARSH criteria, we consider celiac disease if it is MARSH 2 or MARSH 3, whether 3A, B, or C. And again, the increased intraarterial lymphocytosis with crypt hyperplasia, this is considered MARSH 2. And accordingly, so MARSH 2 or MARSH 3, we consider this patient as celiac disease. And is diagnosed as celiac disease. What's next to be done? Gluten-free diet. So we started the patient on gluten-free diet. And when should we repeat the serology afterwards? Should we repeat after 3 months or 6 months or 9 months? At least 3 months. We repeated the serology after 3 months and it came back 29, from 150 to 29. So this is keeping on with the diagnosis of celiac disease. Unfortunately, there was partial improvement of the abdominal pain and the weight gain improved slightly. However, the mother is still complaining of this greasy stools that is passing in the toilet. Sorry for the picture, although there is no smell, no problem with picture. That's what I say to my patients in the clinic. So we have this greasy stool. It's a fatty stool. It's a steatorrhea, and there is too much fat in the stool. It's a sign of malabsorption. There are inflating fats, and the problem could affect one of several conditions. When you suspect steatorrhea, we have a bulky, loose, greasy, foamy, light-colored, smelly, floating, harsh, hard to flush. However, sometimes early stages aren't that dramatic notice effect. However, the fat droplets were found also in the stool analysis. Among the micronutrients digestion and absorption, it's involved in complex mechanism, and the triglycerides are initially emulsified by the bile acid, then hydrolyzed by the pancreatic lipase, and this will lead to this fatty stools. Therefore, digesting fats takes cooperation between several organs, the small intestine, and also the pancreas and the liver. Hence, the disease affecting these organs will lead to the steatorrhea. Either we have an exocrine pancreatic insufficiency like pancreatitis and cystic fibrosis and gallstone pancreatitis, or the bile duct and liver like lichen cholangitis, cholestasis, and the patient did not have any sign of jaundice, and the small intestinal like celiac, Crohn's, gargiasis, and SIBO, small bowel bacterial overgrowth. And how we are going to diagnose the steatorrhea clinically by refusing the greasy stools, and if we have any symptoms of malabsorption, and the lab, if we have fat droplets in the stool analysis, D-dilose test and Sudan 3, and we also do the fecal elastase in such patients. So we did the fecal elastase. A value of more than 200 is considered normal, and abnormal between, and atomic stools if you have less than. For chronic pancreatitis, also we might have pancreatic calcification on CTs, and the MRCP or ERCP can offer detailed evaluation of the pancreatic ducts if they have dilatations also. And this is ruled out as general for steatorrhea. We measured for steatorrhea the celiac disease, and also we concluded that the patients with the duodenal biopsy came out to be positive. Other differential diagnoses is IBS, infections, carbohydrate malabsorption, and laxative use. And these are some of the complications for steatorrhea: patients with fat malabsorptions, deficiencies in fat-soluble vitamins, poor bone health, iron deficiency, pancreatic pseudocysts and seizures, and sometimes cirrhosis in very early stages. And we have to treat the underlying conditions, and as you mentioned, we give the pancreatic enzyme replacement and increase the MCTs in such a diet with some fat restriction, and give the fat-soluble vitamins, and depend on the underlying cause of such condition. But mostly patients will have a good prognosis, and in cystic fibrosis you supply with them, and usually they have a good prognosis. Back to our case, we did the fecal elastase as we mentioned, and it was markedly reduced below 100. So this patient also has pancreatic insufficiency as well as the condition of the celiac disease that we mentioned at the first. So the sweat chloride was performed and was 55. This is considered indeterminate in between. You should repeat it. And what else should we do for such patients if you are suspecting cystic fibrosis? We did the genetic testing and it came back homozygous. So this patient was diagnosed as cystic fibrosis. So we made the pancreatic enzyme replacement and gave the fat-soluble vitamins and the MCT formulas that's available in our market, and the patient started to improve. So we have celiac disease and we have cystic fibrosis. Does he really have celiac disease? Do we have two common diagnoses?
ممكن في association.
The mother by itself told herself, now we have cystic fibrosis and I'm getting fat soluble and getting pancreatic enzymes and gluten-free diet, or these are too much for me. So she started to regain back her gluten in diet for 2 months. And it came back with some symptoms. So we repeated the anti-TTG IgA, which was 29. It came back to be 102. So this patient did have a combination of two, the 4 years with chronic diarrhea, rhesus steatorrhea, and with proved celiac disease by biopsy and proved cystic fibrosis by the genetic testing. And this is a case study that was published in 2021 between cystic fibrosis and celiac disease case record. And we have this another case in our hospital. And thank you, my team in the gastroenterology unit. And looking forward to see you 15 and 16 May. Thank you very much for your attention.
Thank you, Professor Ayman, for this interesting case, which in my opinion should also be published as a second case report for this